Welcome to the Hard Things About Healthcare, where we get into the business and operations of healthcare that clinicians face every day, the challenges they present to delivering care and running clinics, and how they overcome them. The Hard Things About Healthcare is brought to you by Honey Health, the connected care platform for modern healthcare teams. I'm Matt Faustman, type 1 diabetic and co-founder and CEO of Honey Health.
I'm Ginger Vieira. I've lived with type 1 diabetes for 25 years. I'm a diabetes author, speaker, and content specialist. Today, we are welcoming Dr. Halis Akturk to the show. He is a leading endocrinologist at the Barbara Davis Center for Diabetes. He's also an associate professor of medicine at the University of Colorado, specializing in diabetes care and innovative diabetes technologies. With extensive experience in both clinical practice and research, he's dedicated to improving patient outcomes through personalized care and the latest in digital health solutions. Dr. Akturk, thank you for being here. It is great to see you. I know I've had the pleasure of interviewing you in the past on some of your research. I want to dive right in and ask you, why do you work in diabetes?
It's a little bit personal to me, and I work in the type 1 diabetes field in the last 8 years only for type 1 diabetes. I'm a physician scientist. I do clinical research and I see patients with type 1 diabetes. I have a family history of type 1 diabetes. I lost my uncle due to the complications related to type 1 diabetes when I was in medical school. And when I was in medical school, I was taking care of him, and then I witnessed that he was losing his eyesight and then kidneys, then some amputations related to diabetes. So obviously there were no diabetes technologies that time. I'm talking about like almost 15-20 years ago, and not good, diabetes care, and not good medications that we have right now. So that kind of wanted me to make an impact of the people living with type 1 diabetes in the future.
Wow. Okay. Well, thank you. As someone who's lived with type 1 for a couple decades, and I know Matt feels the same way, I love hearing that you are 100% dedicated to type 1. That's awesome.
Ginger already said it, but yeah, that resonates a lot. My entire family has type 1. My dad, my brother, myself. I was actually diagnosed 10 years ago. So being able to seek out great care was important. And that was kind of how we started coming up with the idea for Honey Health was because of that. It was the interactions with my endocrinologist and seeing her frustrations that ultimately led to this. So that resonates a lot, and it's amazing that you've dedicated so much time and such a big part of your life to diabetes.
And it sounds like
conversation today will be about.
Yeah, and we're going to be talking a lot about tech and data, and it sounds like Matt was diagnosed kind of when the data was and the tech was all getting going. I was diagnosed kind of right before, and the tech back then didn't give you any data. I was diagnosed in 1999, so it's very interesting when a person is diagnosed, has such an impact on their relationship with diabetes, and those newly diagnosed people today, what's available today is incredible.
Yeah, for sure, especially the diabetes technology has changed a lot in the last 10 years and making a huge difference.
Yeah. Well, that's actually related to our first question, and so we'll dive into it. There's been, and this is all around closed loop systems, which I know is something that's near and dear to your heart. And there's been so much progress with hybrid closed loop systems, insulin pumps, CGMs, the last 10 years and just even the last 5 years. Yeah, how have you seen these technologies really evolving in real world clinical settings to make life easier, not just for patients, but then also for clinicians? Like, how is that changing how you're doing your work when you have all of these new systems that they're quickly changing as well?
So let's start from the people with type 1 diabetes standpoint. So if you look at how things evolved, if you look at I call them first generation. I know that the CGMs have evolved in the last 30 years, but I call the first generation CGMs introduced 2014-15, and it's coming up with the first generation of the hybrid closed-loop systems in 2017. And then since then, there is a huge, rapid increase in use and also the development. Now we are using no calibration CGMs, small insulin pumps that interact with the CGM systems and deliver the insulin automatically. So they suspend the insulin when you have a hypoglycemia, or it predicts that there is a hypoglycemia coming up, and it suspends or give more insulin if your blood sugars are supposed to be going up. So that changed a lot of the A1C and the glycemic management in type 1 diabetes. It's a game changer. So AID systems and with CGM integrated and changed the type 1 diabetes landscape. And before then, people were doing the finger sticks. They were doing finger sticks, and when you do a finger stick, you can only get a snapshot of what's going on that time, but you don't know anything about the trends. So if you are not using a continuous glucose monitor, you only know what your blood sugar is. Let's say that it's 235. So most of the time what the people are doing, okay, probably that's a little high, I should get a little more insulin. But maybe if you are using a continuous glucose monitor, it can be 235 and going down because you are seeing an arrow with a trend, right? And then so maybe you don't need that. You need to wait. So same thing with AID systems. If your sensor glucose is showing that it's going down, your AID is already slowing down the insulin. And then it just prevents the hypoglycemia, and it really increased the people's confidence in life, quality of sleep, quality of life, and obviously all the parameters that we measure right now with the A1C, time in range, all the CGM metrics decreased hypoglycemia and decreased, even the DKA and the severe hypoglycemic events, everything decreased. So this is the user's, standpoint. If you are looking at the providers, to answer your question on the both side, 10 years ago, when I see somebody with type 1 diabetes, I was looking at, okay, let's look at how many times you are in a finger stick, how much insulin you are taking, and let's make a change in here and there. And I have to make a decision based on the 2, 3, 5, 10, whatever I can see. If I'm lucky, I can get 4 or 5 in a week, the finger stick most of the time. And that's the reality. Now I have this, people are using CGM and AID. And in our clinic, people are using, for example, in our adult clinic, and I'm an adult endocrinologist, and 75% of the people are using AID and 80% of the people are using CGM. So that's a very high
That's
number.
impressive. That's impressive because in some clinics, right, isn't it much lower? It's like 30% AID.
And we are one of the highest in the type 1 the exchange
Okay.
group. So because we are a very tech savvy clinic, we do a lot of research here. So when I'm coming to the answering the question is that obviously it makes my job easier because I have a lot of data. I don't make decision based on 2, 3 blood sugar results, and I make decision more than 10,000 of measurements that some CGMs are measuring every 1 minute, some of them measuring every 5 minutes. So I am just making a decision based on that. So it also increases my confidence to make a decision, and then I can just change that. Okay, let's change this part and let's change this part. Also in AID systems, I can be more flexible for the day and night. If somebody is using an injection, I have to change the basal insulin. I can change all day, unfortunately. But in the AID systems, I can customize things, people's life for their night shift, day shift, for their exercise and for their food and their lifestyle and other things for the weekends. So I can make a lot of changes. So it's more a customizable system for the people's life.
When I look back, when I think back to when I was managing type 1 diabetes in high school, right? That was the early 2000s. I don't remember kind of wondering what my blood sugar was all day the way I do today because I can look at it every 5 seconds. And you also, I mean, we had to run our blood sugars higher because of that, right? Because we could only test 4 times a day. It's just such a different experience. And the expectation back then, I remember it was considered extremely dangerous to have an A1C around 6. And now, it's becoming more and more common for those with access to the right tools and education.
Yeah, especially, previously what the people were doing, especially the pediatric population, they were eating something before going to bed. So it was even in the diabetes education models like 20, 30 years ago. Oh, you have to drink milk or you have to eat a snack before going to bed just to prevent hypoglycemia overnight. So what we did in many decades that we let the blood glucose go high overnight, and that contributed to significant higher A1Cs. But now we are doing the opposite with the AID systems. Actually, we are far more aggressive overnight because there is no interference, system can work better, there is no exercise, there is no food, and we can give more insulin to decrease the blood glucose overnight to a reasonably to a normal level. And that's one of the biggest things that we are achieving right now, great A1Cs in our patients.
It's amazing. There's a lot of different permutations of these systems. And so as you're going from patient to patient to patient, how are you managing the various permutations of these technologies, right? And yes, you're having to adjust basals and bolus calculations, but is there any context switching for you as you're going from one system to the next system to the next? And how do you manage that? And I feel like there's constantly changes that are happening with each of these technologies. So how are you managing that? And where are there any challenges that ultimately come up, and how might you overcome them?
I think the biggest challenge is for the providers and the users are what I can change that makes an impact in the AID systems. Because not everything you change affects the system, and there are different companies making different systems. They use different algorithms, and in one system, when you change the basal insulin, it means nothing. But on the other hand, in another system, if you change the basal insulin, it increases or decreases the basal delivery. Same thing for the active insulin time, or other certain things that there should be a fair conversation with the users about that. The education is the key, and also the provider education is the key, that what settings we can change in certain systems, and the comparison, that's the key for the education. And then you have to explain that the reason behind it, the algorithm, a little bit more for the understandable language, and for not only for the users, also for the providers. Unfortunately, I see some people are using these pumps, and then they have been changing the settings that there is no effect at all, and they got frustrated with the systems, and they think that it's not working for them, or they have a special type of diabetes, or that system is not working. But especially they were just using something else. I mean, just think about it. You are driving a car and you have to accelerate the speed, and you're just turning on the radio. You cannot expect that you will go faster, right? And there is like two different things. So you need to know what to do when you are driving. Same thing with your AID systems and diabetes technologies. You need to know what to do when you are high or low, and what to change. And every year, that's a good thing, is there is another system is coming up, and then our job is to provide education and learn, and also teach and to the patients and the other providers of what we can change and the main differences of the systems.
Some systems you can make more changes than others? I know some physicians refer to it as how many levers they can pull, right? And so it can be unnerving for a physician to prescribe an AID system in the first place because they can't pull as many levers. And then as you get into like the leading, the 4 current FDA approved systems, the number of levers you can pull goes from like 3 to 0 practically.
Correct. And some of them can be a little more complicated, some of them can be more simplified. I think there is nothing one fits for all. I think that's something we should be discussing with our patients, and also the providers should be, because another problem is when you get an AID system, sometimes you'll be locked 4 to 5 years with your insurance, and then you may not change that.
Yeah.
And unfortunately, some users don't know that, and they have a system, they just come and they say, oh, I want to change this, and the insurance doesn't want to change that. They have to pay a lot of money.
Sure.
So that's pros and cons, a lot of things, we need to discuss. Now we are creating with the ADA some educational materials, and I made for ADA to how to start AID systems for the provider.
Wow, good.
And
That
it
is
will be
critical.
published very soon. So
Okay.
step by step, actually, what you need to do, what you need to discuss, and other things with the patient side and the provider side.
Okay, and speaking of supporting providers in learning AID systems, with that comes like a massive amount of data. How do you juggle all that data and what obstacles and then what kind of things do you think that you could help other providers with? Because that's a huge part of the training.
I think 20 years ago we were complaining we don't have any data at all. So
Yeah.
what can we do? Now we are complaining we have so much data. What can we do? So what should we do right now? So I think having a lot of data is great, especially for research. So in clinical practice, we may not need all of them. So first of all, we have to decide like what should we looking at? Are we looking at the last 2 weeks? Are we looking at last 1 week? Are we looking at last 1 month? So the current consensus is right now, even though it has its own issues and the pros and cons, it's suggesting looking at the last 2 weeks. So based on the CGM metrics and AID, we can focus on the last 2 weeks, and then we can try to compare them. Most of the systems compare your last 2 weeks with the previous 2 weeks, or whenever you want, you can customize that, and then we can just look at this data. But obviously, every system is different. There are so many different systems. There are pages and pages. So you have to prioritize what you need to focus, and in terms of your downloading platforms, in terms of your using your data, especially time is should be sufficient when you are taking care of people with type 1 diabetes. So unfortunately, most of the physicians say they don't have time, and they see patients back to back, so they sometimes get a little scared of looking at a lot of data. So you have to be very precise and looking at as low as data, but as sufficient as possible.
How much of an issue is created because the data isn't all in the EHR, right? And even on the research side, manually, but having to consolidate all of those different data sets, which are effectively in siloed locations or on patients' devices. So, how much of a hurdle does that create from a clinical and research perspective?
It is a big hurdle. So the not integrating the data, CGM or AID data, to do electronic health records, and that's a big hurdle. So, and I would say most of the centers, most of the clinics don't integrate that, unfortunately. And then they had to use some third party, paid or non-profit systems to download the CGM or AID, or individually you need to download every single system's device to do the same platform that are compatible with. The problem is you have to change the passwords every 1 month or every 3 months in each system, and every system passwords requirements are different. People that are coming to your clinic should be sharing with your clinic, and sometimes that sharing takes time. If they shouldn't be disconnecting on that, and if they are using an app, they should be continue using that app, so that can just send to the cloud, and that can send it to your system. You can pull the data from there. So that takes a lot of time. So only a couple very efficient clinics can do that, but also requires a lot of human power, and there should be some ways that to do that in a better way.
Do you have any advice for other endocrinologists just in when they're looking at all that data? Where do they start? Because you just have so much. Is it time and range? Is it hypos, highs, risk of DKA? Where do you start?
The first thing they need to look at, obviously the AGP, ambulatory glucose profile page, in the CGMs or in the AID systems, and it just gives you a snapshot of what's going on all over in the last 2 weeks. And then based on that, you can just try to customize your goals and try to encourage the users about the good things, and then they focus on the things that needs to be improved. And then based on this AGP page, you can look at the use. Obviously, first thing is if this patient is using or not, and then your time in range, time below range, is this patient is achieving a good amount of relatively normal glycemia, or then having any hypoglycemia. And then you can just focus on the what's going on based on that. Then you can look at the necessary pages that you focus to for the basal and bolus ratios and the bolusing habits, and is this person is bolusing enough or timely, and you can just discuss based on that. And good and bad, and the systems are you can just download pages and pages. You can have a 60 to 80 pages of 2 weeks of report and in front of you, and depends on what you want to do. So, and most of the time you need to focus on the main things, and the first couple pages you need to choose, and then you can look at the settings and you can change if you have a lot of time to change, and you can also change that if you want to look at that. And by the time, obviously, the providers will get used to looking at the more data, and then I think it will make things a little bit faster.
Okay. It's not easy. I mean, it really requires a lot of education and practice and training on the clinician's part.
Definitely.
Oh, kind of a side question, but related to this. Uh, AI and generative AI is all the rage right now. Have you personally, or has the clinic looked into ways of leveraging that technology to summarize the data? And there are limitations when it comes to generative AI, when it comes to math and calculations. It's getting better and better. But is that an area that you personally have looked into to make the data summarization easier, or maybe you're all looking at from a more of a clinic-wide perspective?
That's a good question. So AI and using type 1 diabetes, I think, will help a lot. In the first generations, some of the CGM or pump systems are already suggesting, based on this report, patients should be increasing the basal insulin. Based on this report, patients should be doing this or that. There are some online platforms using that also. You download and just gives you a guidance. Okay, increase your basal insulin, decrease your bolus insulin, or change your carb ratio, or whatever. The problem is in type 1 diabetes is very user dependent also. So you have to be talking to your patient as a provider. It's not looking at EKG, unfortunately, and a CGM report. So based on a CGM report, sometimes people are sending me, oh, this is a very hard case, or you say, can you have a look at you? Can you tell me your opinion about this AID? What can I do in terms of the pump settings? And I said, I don't know anything about this person. So that's the problem. If you don't feed the AI with the habits of the person or what this person is doing, it will be hard to make a decision. The answer is always like, oh, if the blood sugar is high, sometimes the answer is not increasing the insulin. So if then you have to ask the patient, I always ask when I'm looking at what time do you wake up, how many meals do you eat, what time do you exercise? And when you are looking at the data, you have to be considering these things. We can integrate all of these things to an AI system. Why not? And it could be done. But in the current settings, and we are trying to make things more simplified, like an EKG. And unfortunately, it's not working. If somebody says that, if, for example, I saw a patient last week and blood sugars are high all night, and I started asking what's going on between you wake up until you just go to bed. And he told me that he's eating one bowl of cereal every night just for a childhood habit. So, and then other than increasing the insulin, I said, should we just cut down or stop this one, or just, and he's like, I mean, why not? I'll just get used to this. I was told that I will have a low blood sugar if I don't do that. Actually, I don't like doing that. And I said, okay, let's don't do that. And the problem solved on its own. So without touching even the pump, settings. So if you are feeding your, machine learning with these things in a personal level, I think these things will be okay. I think we can get a lot of help because we don't have enough endocrinologists, we don't have enough people, providers to care for the people, not only for type 1 diabetes, also people are using insulin for type 1 or type 2. And I think that will help a lot. And then there'll be some, obviously, accuracy or precision in terms of these systems that can be used, but it requires more user input. That's how I see.
So, and that's such a great, that whole thing just brings up such a great point that AID systems are not magic. The people with diabetes still have to do a lot of learning, and they still have to intervene and make decisions throughout the day. Is it fewer decisions? Absolutely. I'm actually old school. I'm using injected insulin, and then I use inhaled insulin. So I like low tech along with the CGM, of course. But that's just such a great emphasis on that. Education is still critical. You can't just pop someone on this tech and send them off on their way. And he's also, it sounded like your patient was perhaps following very outdated diabetes advice where you have to eat before bed, like you said earlier, to stay alive through the night. And we don't need to do that anymore, but not everyone gets that education.
That's very true, yes.
Related to kind of the different technologies that we're talking about, one of the other major topics that just continues to come up amongst health systems and clinics is remote care, and the necessity of it, the importance of it, just the prevalence of it. How have you seen remote care change over the last 5 to 10 years, good and bad? And what are some of the unique challenges that you see with kind of this quickly accelerating theme in care? At least ostensively, when you look at what we're reading, what we're seeing at conferences, et cetera, it feels like everyone's talking about remote care in one way, shape, or form.
I think everything changed with COVID. So when we had COVID, and some clinics were doing already telemedicine, and some clinics have no idea. And then we realized that as endocrinologists, okay, what should we do right now? And then people are not coming here, we need to look at some data. So that actually changed the world of the remote monitoring in diabetes care. I think the COVID probably one of the only things that did good in this world, and then it just promoted to be having more efficient with the remote care. And then we learned a lot that, okay, how should we access to data, what should we do? And then it caused a lot of problems because not everybody was sharing their CGM or AID information with us. So people were not tech savvy to do that at home. And after that, I think it turns to a routine thing to access to people are living in more remote areas, and people may not come here for other things. And there are some recent studies show that there are even the people are with disparities in the healthcare that can actually, when if you offer them a remote healthcare, and it can just follow up more other than in-person care. So in diabetes care, I'm mostly talking about type 1 diabetes. So it changed a lot of things in the remote monitoring in type 1 diabetes especially.
At the Barbara Davis Center, you have patients coming from very far away, right? I mean, like states away.
Yeah.
When you find that they are not sharing their data, is it that they're not comfortable sharing their data? They don't know how to share their data? They don't think they need to share their data?
And most of the time, they don't know how to share the data. So you have to send instructions. Sometimes somebody needs to, go through with the steps. And sometimes there is an issue, if you don't access to data in remote care, obviously that's a big problem. And then, so now we have a system too, with every different system is different. So we have a system that when somebody wants to see a remote, care with one of the providers, we just send them some instructions based on which system they are using, and we are just checking. Somebody's checking one day before if we have access to data or not. And if we access data, we always access, we look at that. But that's sometimes causes frustration because sometimes they are not able to do that, because even though we give them instructions, they still need to do that. So there should be a better way of definitely doing that.
Right.
And
It sounds like it's creating an extra step for
Def-
your support team. Yeah.
yes. And if we see people in remote, if we have access to their data, we can see more people in we can spend more time even with the people, because we don't need to deal with this, when people are here and other things. We do, physical exam and labs and other things, once a year or every 6 months. So if we see the people more often than that, especially for new onsets and other things, I think it's a time saver for everybody. And then, and there's this remote care. So.
For you specifically, and this probably changed significantly since COVID, but now what percentage of your patients are you seeing in person versus remotely over a video call? And do you see that changing as we move forward for one reason or another? I'm curious if there's a driver for moving in one direction, whether it's in person or over video.
I mean, in COVID time, obviously almost 100% people, we were seeing as remote, and then it kind of decreased significantly. Now it's ramping up again. I would say 20-25% of the people are, up to BC remote. And then mostly we live in Colorado. Most people are living in the mountains, and especially in winter is coming, so people don't want to drive in snow and other things. It's 4 to 6
Yeah.
hours sometimes driving is far away. And I think it's increasing, and the people are realizing that, okay, I have an app, I can download this here, it just sends to the cloud, or I can use this, app, CGM or AID. If I connect in the clinic, once they connect, then we have access that. So I think it's getting easier. People are also getting to know more about the remote care, that we can do that. Some people were not even aware of that. So
One more question. With the amount of options out there today, between tools and newer medications that are being prescribed off label and all of the technology, how do you develop a patient's care plan? How do you decide when to introduce which type of tech or which type of medicines?
good question. So we try to introduce diabetes technologies in very early stages in type 1 diabetes care. So our whole goal is a person just diagnosed with type 1 diabetes is living with a CGM on his or her arm the same day that I saw that person.
Wow. All right.
So, and in our research, when we looked at the 7-year follow-up, and we did a study here at the Barbara Davis Center, and we saw that the people are starting the CGM, especially in the first 6 months, and doing great in the next 7 years compared to people started the CGM later or never used at all. And there are significant A1C differences.
This
And
award, this research won an award at ADA last year, didn't it? 2 years ago?
this was, yes, yeah,
Yes.
probably, yeah. And then, so for the AIDs, and I think it's a case by case decision, and we try to introduce that as early as possible. But we would like to mostly focus on the diabetes education and CGM first. And we try to introduce in the 3 or 6 months later. And that's kind of a more, again, common, practice in our clinic, but we are not against to even using earlier too. So it depends on the person, it depends on the needs and other things. But our all focus is decreasing the burden, increasing the time in range, and decreasing the hemoglobin A1C, obviously with preventing the decay and hypoglycemia. If we can do this with injections, inhaled insulin or injectable insulin, or we can do this with AID, I don't think it matters. So, but the CGM is the key here, is the decision maker. So we have to be using the CGM in all people.
Okay. I'm all for it.
What do you see as some of the biggest blockers to introducing some of the newest and some of the more innovative technologies that are starting to come out? Whether maybe it's insurance, maybe it's regulatory. What do you see as some of the things that get in your way of leveraging some of these technologies for patients when you determine that would probably be the best thing for them?
I think I would say the first thing is insurance, prior authorizations, and then takes a lot of time, and it causes a lot of frustrations and for unknowing for everybody. And then I think this prior authorization frustrations and decrease the provider patient relationship, trust, and other things you have to be explaining step by step. And other than that, the cost, obviously, and even the insurance covers it, may be a high cost still. Co-payments can be a little bit high, and also the support, the company's support for the system, for the CGM or an AID or a new medication. Is there a local support for this, or is there a national support for this? And also if the systems are connected to CGMs or AID to each other. And then if there's a new CGM, sometimes people want to wait and see the results, or sometimes provider wants to wait and see the results on their own. So I think there are so many different factors that are limiting to initiate some new technologies. But I would say in recent years, people are more open-minded about the diabetes technologies, and they are eagerly learning from online or following and internet and getting a lot of information. When we try to discuss with the people, they already know that, and so it will be easier to open the conversation.
Got it. Got it. When it comes to prior authorizations and insurance, that's the first thing you said, so I'll just ask on that or follow up on that. Anything that you all have done or you've learned personally to help overcome some of those challenges or just make that easier for yourself and for your patients?
So we have a lot of people are working here to do that. So we have a huge staff are working on that, and then I think that also unfortunately increases the healthcare costs. And then because somebody is prescribing a medication, you have to convince the insurance that that person needs that medication. Then insurance tries to convince you that is really this patient needing this, to do that, and then it's kind of a confirmation back and forth, and it's it takes a lot of time, and then it takes a lot of money also from everybody. I think that's so we have a system, we try our best, we try to learn the system and mitigate the system, and so we try to do as smooth as possible, but it still takes time, and sometimes we have roadblocks, unfortunately, and sometimes people cannot get that, and then we offer different options like research or some different option that a different medication or different CGM or a different pump, and so they can be still involved, and then we try our best to help our patients.
Well, thank you so much, Dr. Akturk, not only for joining us today, but also the dedication that you have put into helping people with type 1 diabetes, especially all of that battling insurance companies. That's not medicine. You don't even get that. It's taking away from your ability to serve your patients. So thank you for everything that you're doing to help people with type 1.
And I appreciate this opportunity to, and I would like to thank you too also to giving an opportunity to explain and discuss the problems and solutions related to type 1 diabetes.
Thank you so much. We appreciate you sharing all of this. It's a great discussion, and I think to your point, there's not enough places where this is being discussed, but everyone wants to understand how their colleagues out in the field and in research are solving these problems. So thank you so much.